Please welcome Dr. Danny Jacobs, President of Oregon Health and Science University.
So 2018 was the first time in U.S. history where life expectancy decreased 2 years in a row since World War I. That's happening even though we're spending more than ever on health care, about 18% of our gross domestic product. Now, it's true that most of the world's advances in patient care, education, and research have occurred at academic health centers like OHSU, but many of these advances have occurred too slowly. It took about 13 years for the first patient to get penicillin, and about 25 years to develop an effective and safe polio vaccine. We need to go faster. We're not doing enough. People are suffering. I think the answers are out there in the data, but we must find them. I call those when the light bulbs click, when they fire aha moments. And those are what we need to find. Now, there can be a difference, and an important difference, between data and information. Let me tell you a story. So a father is watching a baseball game with his 5-year-old son, and the father has to get up and go to the restroom. He comes back and says to his son, "What's the score?" The son says proudly, 6-4, Dad. And then Dad says, "Well, who's winning?" The son thought about it for a minute and then proudly said, "Well, 6 is, Dad." So I'll use the words data and information interchangeably in this presentation, but it's important to realize there can be a difference, and that difference speaks to context and also asking the right questions. I have 3 real-life examples for you in education, research, and patient care. The first is in education. Let me take you back to 1986. Here's a picture of the 5 graduating chief residents at the Hospital of University of Pennsylvania. And one person forgot that it was official photo day and wore sneakers and still was allowed to graduate. In any case, we were trained the same way surgeons had been trained for 100 years, to treat tissues gently, to knit them together with care and love, and to pay meticulous attention to detail. The thought being that if we cut well and sewed well, our patients would do well. And furthermore, no matter how skilled we were or were not when we entered, by the time we finished training, our patients would all do about the same. But is it really that simple? Colleagues at the University of Michigan decided to find out. 20 board-certified and experienced surgeons agreed to submit videos of themselves performing an operation. They submitted them anonymously, and each of these videos were reviewed by at least 10 other peer-reviewed surgeons for skill on a scale of 1 to 5, 1 being like what you'd expect for a beginning chief surgical resident, and 5 being what you might expect from the master surgeon. Fair enough. They took it one step further, and using a nationwide database in Michigan, they correlated how skilled the surgeons were with outcomes. Here's a summary of their findings. Now, surgeon skill ratings clustered in a relatively narrow range. You can see there from about 2.6 to about 5, where the highest rating was 4.8. The average score was a 3.6. So think of the surgeons around the lower end as sort of the C surgeons, and then those at the higher end, the one surgeon with a 4.8 as being an A or an A minus. So fair enough, there were observable differences in skill, but how did their patients do? So it turned out when you looked at the outcomes, how well the patients did for those surgeons that were in the top 25%, their patients had 3 times fewer complications, they got out of the operating room 50% faster, and were 5 times less likely to die. So this changed thinking about surgical training. It prompted the need to include more deliberate practice, as well as to use simulation technology to try and better prepare the residents. And it also prompted the need to look more carefully at the characteristics, trainings, and personalities of the most skilled surgeons. So this was a moment of clarity. It was a moment of insight. It was an aha moment that came from just looking at videos of operations. Meaningful differences in skill were detected by these videos. So that's my first story. Let me tell you a second story related to research. Now, clinical research typically goes something like this. You try to identify as many patients as possible, oftentimes thousands. They are as much alike as possible. And then they are randomized, split into two groups. One group typically gets the active drug, and the other group gets a placebo, something that has no effect. And in these studies, neither the patients nor the caregivers know which group they're in. It's blinded. And then, over time, often years, the results are collected, and depending upon the findings, they may change practice. Now, not too long ago, the prognosis for a 50-year-old woman with highly aggressive breast cancer was terrible, was dire. Depending on where she lived, she might have access to clinical research. She might be able to enroll in the clinical trial. She wouldn't know beforehand whether she got the drug or the inactive drug, the placebo. Now, in those kinds of studies, typically a 30% response rate would be very, very good, if only because when single drugs are used, oftentimes over time, the patient's tumor becomes resistant. And that's not found out until the very end. So at the state's only comprehensive cancer center, the Knight Cancer Research Institute that many of you all supported, thank you for that, Dr. Drucker and his colleagues said, can we do better? And it led to something they're calling the SMART platform. We have the patient tumor. We know very much. We know a lot about its biology, its behavior. We know about its DNA. We know about its proteins. We know the same information about the patient. We have studies in the literature that talked about how drugs behave. We have libraries of drugs, and we know their behaviors, as I just said. We have the electronic medical record. And now, for the first time, we can image cellular architecture, the very fabric of a cell, at a level that's 500,000 times smaller than the human hair. 500,000 times smaller. So the OHSU scientists said, okay, recognizing that cancers can change rapidly, what if we develop this new platform and included data from everywhere? And we use that data to identify and adjust different drug combinations and therapies to overwhelm the tumor's ability to respond. You might think of that as a 1-2 or even a 3-4 punch. So what were the results? The preliminary findings are dramatic, extraordinary in fact. 2.5 times greater response from the patients enrolled in this trial, and that means about a 70% or greater response rate. Now, how did this happen? This resulted from thinking differently about sources and uses of data. It led to better research designs and better outcomes. The light bulbs were firing. It led to another aha moment. This is precision oncology, cancer treatment customized and tailored to the individual patient. My third story is about patient care. At my last job in Galveston, very hot, very humid island community, I was also socioeconomically deprived. About a quarter of the folks there were below the poverty level. We were trying to do everything we could to improve patient care and prevent visits to the emergency room or rehospitalization for folks with chronic diseases. We had identified some folks that were regular visitors based on our electronic medical record. We would treat them, state-of-the-art, best practice, see them improve, discharge them, only to have the cycle repeat itself over and over again. We were still missing something. I'll never forget a particular patient back in August of 2016. We had found through our medical record that there was a 60-year-old woman with bad heart and bad lungs who was regularly and repeatedly admitted to our hospital after coming to the emergency room, about 9 times in 2 months. Each of those visits, not counting the ambulance or the hospitalization, cost about $7,000 each. So we figured out how to send a community health worker out to her home, and she found that this patient lived at the top of a flight, a couple flights of stairs. She had no air conditioning, and so when the heat in Galveston became oppressive, she'd have to come to the emergency room. So this was a new piece of data. We then worked with a local not-for-profit and were able to buy her an air conditioner. And once we did that, her visits to the hospital stopped. So a $200 air conditioner saved thousands of dollars while also improving health and well-being for this patient and many like her. So we had our moment of greater clarity, our moment of insight, our aha moment. If we hadn't been so traditionally incremental, we would have thought of adding environmental data sooner. Our patients and others like her would likely have improved faster. Later on, we found out about the great work y'all had done here in Oregon, where you had keyed some interventions based on a similar scenario. Made us wonder, why did it take us so long to realize that folks had already done this in Oregon? But it led to a follow-up question, which is, what was next for that academic health center where I was working? And perhaps more importantly, what do we do next in Oregon? So these are 3 stories. What do they have in common? Each talked and spoke about thinking differently about sources and uses of data, videos, a new approach to cancer therapy, an air conditioner. In each case, it improved our understanding. It showed the way forward. So, in each case, different people with different perspectives, each with a different piece of the data puzzle, brought those pieces together to identify solutions. Each story was and is an example about how the right kind of information can help skip some rungs on that ladder towards improving health and health care in America. We need to change. We need to do something different. I think that's empowering, expanding, and integrating data sources, including information on social determinants. Now, social determinants are conditions in the places where people live, learn, work, and play. We now realize that social determinants are more important than genetics, 60% at least. Where a person lives determines many things, like access to high-quality schools or nutritious foods, or heck, even finding a safe place to exercise. Perhaps most importantly, where a person lives determines how connected he or she feels to society and to other people. So zip codes are more important, more impactful than genetic codes. And this leads to a fundamental question of our time in health and healthcare. Why treat illness and send people back to live in the same conditions that made them sick in the first place? Isn't a practical definition of insanity, at least one, doing the same thing over and over again, getting the same outcomes but expecting something different? So there is some evidence out there that more holistic approaches can improve socioeconomics. A community in Atlanta worked with community leaders and other stakeholders to revitalize an entire neighborhood through a variety of initiatives focused on education and training, community engagement, economic stability, career development, and financial literacy. What were they able to achieve? A 73% reduction in crime, a 75% improvement in employment, and a 100% acceptance rate to college. So some outcomes in this zip code changed dramatically. Now, were these improvements linked to better health? As far as I can tell, they didn't connect those pieces of the puzzle. But what if they tracked other measures of health and well-being? What if they partnered with others not traditionally engaged directly in patient care? What if they incorporated data from all those sources I described and added in, information from sensors like the one I have on my wrist or the one on my finger that samples physiological measurements hundreds of times per minute? Using data from everywhere to inform decision-making isn't rocket science, although some of the technologies are. It isn't difficult theoretically, although it's tedious, detailed, complicated, and political, perhaps. But there are also important concerns about privacy. But if we were able to develop the appropriate permissions and safeguards and guidelines, what if we were able to connect sources of data for every zip code in Oregon? What could we learn? What kind of impact might we have on 2,000 people in East Portland or our community in Klamath Falls? Pulling all those pieces in, that's precision health. And that would lead to more aha moments. Our challenge and our opportunity is to figure out how to work together more effectively, to realize a world where a massive storehouse of information from everyone, every place, everything is used to improve health and well-being for Oregonians and the nation. 2018 was the first time in U.S. history where life expectancy decreased 2 years in a row since World War I. 2019 is no better. We need to do something different. I think the answer is in the data, but we need to go get it. And frankly, who better than the folks in this room to make that happen? Thank you.